Just for house rules, the rules of conduct when you're in a medical setting, we like to emphasize that it's common courtesy to introduce yourself to the team, maybe both to the doctors and to the patients, so they know, who's that looking at me. Kind of play the student card, because generally people are more favorable if you're just a student there to observe and learn. That you're not like spying on them or something. Be respectful at all times. Follow all instructions of the host doctor. Certainly you can ask questions, but you have to make sure it's at the appropriate time. So if something comes up, but it doesn't seem like a good time to ask it, you just kind of write it down and you save it for later. And then there'll be the occasional patient that won't want you in the room there maybe, and don't take that personally. It's just they want to have it more private, and you can respect their wishes. Try not to speak too much, but be more like taking in what's going on. Of course, there's going to be sometimes some language barriers in the public setting, so you kind of pair up and help each other out in understanding what's going on. Medical people will know more what's going on than non-medical, and then people speaking Cantonese can help translate for people who are like, what are they talking about? Generally for observations though, these are sort of obvious, so you want to be curious and question everything, and actually it comes automatically because you're at the stage where you don't know what's the standard or what's the best or why people are even doing anything. Everything's a blank slate. That's the most opportune time to discover something interesting, to read about it, to figure out why, and then actually try to, how do you do it better? I mean, basically in medicine, the people who are innovating are the people who are asking, how can I do it better? What's going on right now, is there a better way to do it? Maybe not. But essentially it's, you're watching for patterns, you're trying to understand what's really going on. This is just like an introduction. We don't really expect you to understand what's happening. You'll see some frustrations. It may be difficult to document anything that has true insight. And don't take that as you're not good at it or anything like that. It's just this is an opportunity to put yourself in a situation you haven't been in before. And just getting used to that sort of uncomfortable, maybe even awkward situation, it's a good training just for as you're training yourself to be an entrepreneur. So take it like that, try to immerse yourself, empathize with what's going on. And of course for medical, it's really important to just be curious. That way, you're always thinking about how to do it better. So some tips on spotting potential needs. Usually when something's painful, it's a problem, right? I mean, nobody should be suffering when they're going through medical care. Medical care, there is suffering involved, but hopefully you're alleviating suffering. That's the point of medicine. Yes, sometimes the solution does involve some suffering, but maybe there's a better way to do it. If something goes wrong, obviously that's a potential need. Medicine, there's mistakes. There are problems in medicine. We're not even as good as the airline industry, in terms of what happens in medicine. There's a lot of problems that occur, and because it's so complicated, it is not that easy to solve. They're all interlinked. That's particularly with complications. There's always trade-offs and things. You're trying to make people better, and maybe at a population level, you are. But at the individual level, there's some small sacrifice sometimes of a specific patient where on the whole, you're doing good. So that's what doctors have to deal with personally on their own level as they're delivering medical care. Yeah, whenever there's uncertainty, stressful situations, inefficiency, these are obvious times when you can try to improve things. But I think one of the most important ones is dogma. Does anybody know what that means? Yeah, it's just, that's the way we're trained to do it. That's the way I do it. My mentors did it that way, I'm going to do it that way. We don't want to take risks because, I could hurt the patient. So let's just keep doing it the way we always do it. That happens a lot in medicine, and that's not necessarily because of the personality, but it's just because of the safety aspect of, trying something new can be very risky, and who's going to be the one to risk someone's health or life? That's a hard risk to take. Maybe you can risk in an animal model or in a bench lab, but risking in a clinical setting without setting up the proper reasoning for it, IRBs, all these kind of things to make it as safe as possible, that's where you can look for a potential. But other ways to find problems isn't always just by direct observation. You can read a lot in the literature and research. And this is really good for your phase as well, because it's still like a blank slate for cardiology or atrial fibrillation or cardiac rehab or anything. Everything's so brand new. Anything that seems, well, just a bit interesting to you, you can start digging. And there's a lot to dig and a lot to learn. And so much of the information now is online. You can read all different kinds of medical journals. You can research bulletin boards. You can even go on Facebook groups. There's so many different ways to get information that was hard to get access before, but it's starting to get a little bit easier. So it's this kind of like circle, looking at the literature. What does the real life say? What does the literature say? What do the doctors say? Is there alignment there? Are they disagreeing? What's in reality? So finding problems can be from multiple sources. And observations is really about what they do. You may ask them and they say, I do it this way, but then when you watch them in real life, they hold it this way. And so they don't even really realize the changes that they're making in order to make something happen. And that could be your insight in, well, I can make a tool to make you do that better. And look, because you're already doing it that way, but you don't have that tool, you're going to want my tool. And so those are the little insights that can help you get started on something interesting. Of course, you can also say what they directly explain as a problem. Some doctors are better than that than others. Some of them are like, I just hate my EMR. Get rid of my computer if you could. I just want to do it my old way of paper and pencil. So that might not be as valuable. But other doctors may have already sort of that mindset of this kind of training and say, well, if only I had a developer who could have made this for me that would automate my job here, then I'd really love to have that available. And then of course you have to look at what the data says, because you generally want agreement, two things to agree. What the doctor says agrees, and the data also says it agrees. Or what you see doing, and the data confirms it. That way, it's again, making it more valid that you should be working on this. Anybody have any recommendations for others where to look for literature and research? PubMed, okay, there's one. That's a good resource. That's free online. It has the abstracts of all the scientific journals. Generally, there's a paywall to get into the actual journal article, but when you're affiliated with the university, you can have access for free.
Patient support groups, you might find some on that patient needs.
Yeah, so there's actually a lot of online bulletin boards, something like Patients Like Me, or different sites very specific to like migraine headaches or something, and then people are discussing what they do for it, and then that could be access as well as, you have search engines that can search through that and find something interesting.
Google Scholar.
Yeah, so Google Scholar also does everything that is on PubMed, an easier way to search Google. You can search Google for everything. Google intellectual property. Okay. Google Scholar.
What do you think about Science Hub? Have you heard about this website?
Sci-Hub?
Yeah.
The one that's from Russia or something? Yeah. It's basically...
It's a piracy.
Yeah, so what they do is they download the articles and then they re-upload it into their own search engine so that it's free for everyone to get around the paywall.
What do you think about that?
Well, I do believe that the academic industry is a little bit broken on the publishing, like the way that the scientists do all the work. The reviewing is all done by other people for free, and then the publisher charges you a lot. In particular, now when everything's digital, which then the price should be much less compared to printing. So they're trying to preserve their business model from what happened before, but I do think that the cut that they take, there should be more open access, although right now how the open access works, you have to pay for it in order to make the journals open access. So I think it's a challenging thing. I'm not going to commit to one way or another about piracy. But I do think there should be a better way to get access to the information to people who need it at a cheaper cost.
And then in terms of overviews, up to date.
Yeah, so if your institution subscribes to Up to Date, that's an awesome resource that's continually updated by authorities in the field to answer the question. That's actually what I use when my parents ask me a question, and of course it's like not in my field, and I want to know what's the latest on that. I can quickly go on to up to date, and because I know the language, then I can research it and understand it easily, and then interpret it for them. So great, yeah. So we have all these kinds of resources: Google, PubMed, up to date, New England Journal. You can actually also go to government health resources. So sometimes you're looking for stats. You know, you want to know what's the total population involved in this. You go to WHO or NIH, and they have quickly a way for you to help to understand market size and things like that. So look into all the resources. You can go to B-School and look for Frost and Sullivan, or if you have like other access to CDI Insights and things like that. They do a lot of consulting type work to help you understand the industry. So that's the advantage of being at an academic institution. You get free access to expensive stuff. So recommending on the interview side, I think it's easiest for you guys to go in pairs. So in your team, you guys can like pair up, maybe one doctor, one non-doctor, and you can, some people are watching the physician, some people might be talking to the staff. Divide and conquer kind of situation, and flip-flop too. You don't have to be doing the same thing tomorrow the whole time. You just find which situations would you insert yourself to be not disrupting anything, but looks like a good time. Like, okay, now the doctor's finished seeing a bunch of patients. I can pull them aside, ask them a few questions. Or it looks like there's a lot of people waiting in the waiting room, and that one who's waiting at the end is probably going to be there for an hour, and they wouldn't mind talking to a young student who wants to ask them a lot of questions about what's going on here, and they're happy to chat. So to bypass the time. So think about that. Basically introduce yourself and start off easy with warm-up questions before diving into what you really want to know in terms of about that problem or about the solution that already exists and why it's good or not good. If you're doing some more formal interviews, like let's say after this experience tomorrow, because you got to know the physician, you can actually get an interview with them later to answer more questions, follow-up questions, because throughout the week, things are going to come up. You may even want to show them your prototype later on to get some feedback. And it's already starting your network by working with the doctor you have tomorrow. And so you can set up a formal interview, but then again, at that situation, when you typically ask questions, you don't want to ask just all yes/no questions. You really want to get them to tell about a patient story or about a frustrating case they have or something that may give you more insight that even though it didn't happen when you were there, they say it happens all the time and they can share that with you. That's more valuable because that's something that you might not read in the textbook or on the website. And then hopefully you'll keep track of all that information. We always use pictures of notebooks, and then nobody brings a notebook and just use the pocket computer, right? So you can bring your smartphone and record everything, make note of questions you want to come back to. Any suggestions for others on how to do a good interview? I already showed you some answers there, so let's just do it really quickly. This is a good one that I don't do enough. I should allow for silence. Because I'm like, any questions? And then, no questions, okay, move on. No, actually, I should wait longer, because then maybe a question will come up. Yeah, you don't want to, since you're there to gain information from the person, you should let them talk more than you talk. And you shouldn't necessarily guide them unless they're getting way off topic and you just want to bring them back to the topic at hand. So ask a lot of whys to figure things out. Try to encourage stories and try to get more specific. Because you guys are talking a lot about quality of life and about pain and about costs and compliance. Well, you should actually know what is it like specifically in order to know if that is your outcome metric you need to change. With the observations, this is the time for when the clinicians will shine, right? Because they're the medically trained people. They can quickly understand what's going on. Even as a student, you're trained to try to observe. Medicine is a field of pattern recognition. It's a field of figuring out what works best and then trying to apply that to different scenarios. And then you always want to validate everything you see, because otherwise if you only see one case of it and it's a case tomorrow and that's like 1 in a million and you wouldn't know it, but you think, okay, that's the main problem, you need to validate with other sources. And generally not with the same person, hopefully someone else or somewhere else. Because maybe just that person just is always like that but they're an anomaly. So not necessarily worth spending your whole innovation career on one person's anomaly unless it's a really interesting insight that's common, that fits all those other parameters that we talked about on unmet needs. So here's how you validate. You saw an observation, a way to reduce X problem for patients that improves Y. And then you go and validate that with other clinicians, and you go to the literature and you go to research and you say, yep, I do see that's a problem. No one else has published a solution on it. I go and check Google intellectual property, yep, that there's no patents even on this. This seems like fertile ground for doing some concept generation. I'm going to write that down. I think it's a good unmet need. So yeah, it seems like a big market. I know I could make it and do it myself with a prototype, with a minimum viable prototype. Oh, that's going to be fun to work on. Okay, that may bubble to the top in terms of your filtering of which one to try. Of course, you can see what the doctor says. I see a problem, happens 1 to 2 times per year. And then the problem also happens in 60% of the clinics. Okay, now you're getting corroboration that this is compelling unmet need. Remember, you want to find something compelling. Some of the tips on observing. If you hear the doctor say, if I only had a way to do it X, you'd be like, well, I'm going to be that person. I'm going to help you do it. Or dogma. This is just the way how we do it. So that's why I keep doing it this way. Well, did you know that there's this new tool, new technology enabler that can make you do it 10 times faster, 100 times safer? That'd be awesome. So, but they might not be aware. The really innovative people are generally doing something called jerry-rigging. What's that term mean? Anybody know what that term means? Yeah, so you need to stick two things together. You look around, what's available? Oh, I see some tape there. I'll just tape that together, and that's my new tool. So jerry-rigging is just taking whatever you have off the shelf in order to make something happen, instead of formally constructing a product. So when somebody's doing that and they're doing it all the time, well, then maybe that's a cue to, you need to make one of those, because maybe other people would use it too. Of course, bad outcomes, high costs, a lot of morbidity. These are very obvious things that you want to reduce suffering and alleviate the problem. Getting a patient perspective is quite helpful, although the patient perspective may be on more soft things that is not necessarily easy to innovate off when it's a service delivery model. But if it comes to symptoms and the experience of the treatment or diagnosis of a medical problem, then you do want to really take into account the patients, because they're the ones who are going to be using your potential solution or service. And so if you don't have good UX UI design, don't have good buy-in, then nobody's going to even want it. And so even though it's really good but poorly designed, then maybe someone else will do a better one and yours won't win. So you have to also take into account the patient aspects. And providers are definitely one of the gatekeepers. In terms of the stakeholder analysis, essentially everything in medicine goes through one of the providers, whether it's a nurse or a doctor or any other pharmacist, etc. And if they don't champion the product, the patient's not going to use it because they trust the evaluation and expertise of the person delivering to them. So oftentimes that's why you're going back. The doctors are so hard to reach, right? They're busy all the time. You don't have an opportunity to just call one up and ask them with your idea. So you need to figure out what are ways to try to get closer to the people who might be interested in what you're interested in anyway. You become friends and you have an opportunity to work together. And that's how a lot of the companies really get started. It's like a engineering/doctor type pairing that can kickstart things and be the catalyst to move forward. Okay, so we'll do a quick observation right here as a class. So what's going on in this picture? Anyone in the medical side want to describe what's happening? Okay, so first we got a setting. It's in the operating room. And we've got some people in there, they're operating. So yeah, so someone noticed a camera that's right over the operating field that's aimed downward. There's some screen over in the back of the wall, but it looks like there's some other kind of image up there, not the camera image.
There are different tools to perform this operation, and systems are helping with these tools.
Yeah, so it looks like there may be one primary person with a headset, and then there's some assistants there that are holding a bunch of instruments. You don't even have to know what it is, but it's trying to get oriented to the situation. Yeah, so there's definitely blood going on. There's an open wound and stuff's going through the tubes. Okay, yes. How about anything over here? Are you looking at all the different parts? All different kinds of instruments. Maybe there's someone behind the drape. Anybody know who's behind the drape? Anesthesiologist, yeah. Yeah, it's kind of hard to tell which part of the body is open right here. So one way is to kind of help you just get a framework to cover things. What's going on inside of a setting you're not familiar with is to try to use this AEIOU. Activities, environments, interactions, objects, users. That way, it's like, again, a framework to make sure you covered everything. You know, who's there, what are they doing, where is it, what's the interaction, what stuff are they using. This is just very basic, but well then, once, you know, if you're doing a lot of observation, you find out what's normal, and then you can know what's abnormal. But unfortunately, with only one day, you know, you can't really ever get a sense of normalcy, and that's why you can't tell what's abnormal or not good. And that's why a lot of the observations still just come from people inside the medical community daily. Because you have to be there all the time, and it's very hard for a non-medical person to see something and just really understand the scale and the perspective without doing it all the time. But again, this is more of like training to understand, to know what you didn't know before, so that one day you can, if you're in the right setting, keep applying these same principles. Capture your finding. What do you see? What do you hear? You see frustration on someone's face. You know, being observant, figuring it out. And yeah, unfortunately, we don't allow any picture taking. You know, just for patient privacy, rules like that. So respect that, don't take any pictures. Especially don't publish it to social media. It'll cool up in the operating room, that'd be very bad. But you can do your own simple notes and sketches. You can draw things, and that will remind you and trigger what happened. One other way of thinking about observation is the who, what, where, when, why. So we can also, just like the AEIOU, try to figure out what's happening. That way when you read textbooks, you can understand if it's in the same framework as what's described and how you do things, or if they're deviating. And why are they deviating? You may ask them why they do something some way. Because maybe somebody figured out something that was really interesting, but they just, you know, they didn't try to make everyone else do it that way, they just do it that way. And it's now your opportunity to facilitate everyone else to do it the same way to make it better. Observing means pains and gains, so like we discussed before, what are the frustrations, pain points, what's awkward, what's inefficient, people are feeling pain, things are getting delayed. Generally, when you go to the public sector, you see a lot of things. Underserviced, long times, you know, because there's not enough resources to do everything at the same standard. So that's actually why it's also fertile ground to do observations inside of a public setting rather than a private setting. So let's just do a quick little video observation and see if you see any problems in this video here. Let's see if this works.
Somewhere in Afghanistan, an explosion hits a Humvee. A Marine is badly in need of blood, and an Armed Services blood program has been working hard to get that blood to him through a worldwide network of distribution and collection centers. At the heart of that network are the people who donate blood and the people who make it their daily mission to collect it. This unit is called a bubble blood team. We average about 2 to 4 blood drives a week.
So we go from anywhere from Southern PA, all over Maryland, DC metro area, and then Northern Virginia.
This is not a 9 to 5 job. It is a 12 to 12 job.
You go wherever they'll have us, and whatever hours they're available, that's what the hours that we do. So, I mean, if it's a place that's 2 hours away, and they're only available at 7 a.m., then we get up at 4 a.m. and drive out there.
My name is Isaac Jackson, and I'm a phlebotomist for the Armed Services Blood Program. The Armed Services Blood Program was different because the units that we collect go to the military and their dependents. We actually have Air Force and Navy working with us. We used to have some Army, so it's all branches of the military. And we also have contractors and GS workers too.
I'm Staff Sergeant Daniel Ingalls, and I'm a medical lab technician. I worked with the Armed Services Blood Program for about a year and a half. I would say we collect about 60 to 100 units a week. Unit is about a pint of whole blood, which we can actually split that into different products. We split it into red blood cells and plasma. So at least 2 patients are being helped with every unit we collect. We do work more than your average shore duties and Navy time. But I don't want to say we're not working harder than the guys in Afghanistan, so I can't complain too much.
Okay, my work is not hard. Actually, I enjoy doing it, and it is repetitive.
So 4 hours for this wrap, no smoking for the next 30 minutes.
No smoking for the next half an hour. No alcoholic beverages. No heavy lifting for the next 6 hours.
We're going to refrain from extreme sex.
Nothing extreme sex for 24 hours. Exactly.
But just knowing where the blood is going at the end of the day, that keeps us focused on basically providing the safest product for the recipient. So
I don't think I've ever had a job within the Air Force in such direct connection with the wars going on. Before I was just working in a hospital, which was, that's good too, but this one, every week we send a weekly quota pretty much straight over to you, right? In a sense. Feels like I'm contributing more to that than I was before.
To reach that weekly quota, the Bethesda mobile team relies on partners at the blood drive sites to spread the word and bring out donors.
they're the ones that advertise and get the donors to come out and donate. It takes a lot of people, a lot of time to drive out to different sites, so we want to make sure we have a big turnout.
A blood drive only works if people are willing to put aside a small part of their day to show up to donate. One location that always has a good turnout is the U.S. Naval Academy in Annapolis, Maryland.
Major possibility in the fourth platinum shipment at the United States Naval Academy. I'm donating blood every chance I can because here at the Academy there's not too much I can do to aid the front line at all. So this blood is going to people who are fighting and trying to make our country what it is. And one day I could be in their shoes and I'll be depending on this same blood to just try to keep the supply going, kind of pay it forward here. If you're in a position where you can be on a bed one day depending on someone else's blood, and what if that person just didn't feel like going out and donating that day, and that might cost you your life. Just by me giving a pint of blood and save one or maybe two people's lives, and my schedule isn't important to someone else's life.
A donation is able to help 2 or more lives, partly because it separates the red blood cells, which are used for transfusions, and plasma, which is used to bring nutrients and clotting factors to burn victims and other patients. Whole blood and plasma have a longer shelf life, depending on what temperature they're kept at. But there's another component to blood that has a much shorter lifespan. Blood platelets will only last for 5 days, and they require periodic donors.
Platelets simply form the scabs that stop from bleeding. It is extremely important for us to have regular donors we can rely on to collect blood. Platelets only have a shelf life of 5 days, so it's very important for us to have a steady stream of donors coming in to donate on a consistent basis.
One of those regular donors is Major Johnny Perez, an Army program analyst stationed at the Pentagon.
I've been donating platelets with the ASBP for the last almost 3 years. I was a little apprehensive at first because when they explained to me that the blood goes through a machine, filters the platelets out, and then put the blood back in you, I was like, oh, that sounds like a complicated process, but it's not that bad.
At the end of a typical hour-and-a-half long procedure, we're left with one viable platelet product. This product can be given to cancer patients, chemotherapy, treatments that depleted their own natural platelet count, as well as being used in trauma situations. In trauma situations, it's important to have platelets to form these clots and stop that patient from bleeding out.
When I was in Iraq, I lost 2 soldiers when I was a company commander, and I've been wanting to give something back for them. I hadn't found the mechanism or vessel to do that. I chose the SBP because I know it directly supports soldiers and families that are in need.
When you donate to the ASBP, you know that your blood or platelets or whatever it is you're donating is going from you and directly back to one of your fellow service members.
If you're physically capable of giving platelets, I highly recommend you do that. It's an hour-and-a-half up to 2 hours of your life that can help a human being live.
Whether it's platelets or whole blood, it's the regular donors who are helping the Armed Services Blood Program ensure a steady blood supply for the DoD family all over the world. For All Hands Television, I'm Petty Officer Mikkel Smith.
Maybe you guys didn't know how complicated blood draw is and what happens with the blood afterwards. I use this as an example of something called the cycle of care. So essentially, figuring out from end to end what happens to a patient when they either get a procedure done or diagnosis is happening. You follow them through the whole journey, then all of a sudden you can get a different kind of insight. Did you see anything that you thought was inefficient? Or that could be made better? Or do you think it's pretty good the way it is?
There is a shortage of the suppliers of donors, blood donors, and the lack of motivation.
So they certainly need more platelets, it sounds like, because they don't last very long. It takes a long time to get it from people, so there's fewer donors who may be willing to donate.
You don't put blood drives at the back before?
Yeah, so there's a network distribution. In order to collect it, it's a challenge because it's not so easy that you can just collect it anywhere, but yet you need to be there to do it. You need that. You saw even a fast forward to set up how to do it, so it takes a little while.
Blood expires, different parts of the blood expire at different rates, so that also has implications for it. Like they have to get it turned over really fast and sent to wherever it's going to go. So maybe it would be, maybe that's a limiting factor for them.
Yeah, so depending on if you find out, how much are they wasting because it's not getting there, you figure out how much does it cost because of, if you had a way to make it last longer, blah, 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 whatever you think the main problem is about it, or you need more volume, etc., then that helps you start coming up with even a neat statement on something like this.
It seems also there is no synthetic option for this procedure. So we need people and we need natural product. So it can be.
Yeah, so certainly,
synthetically.
if you start thinking about a solution, then you may say, okay, you need synthetic blood, blah, blah, blah. But make sure that you figure out what's part of the whole cycle is most important to work on or adds the most value. So that way you don't immediately go to, oh, I think, in the whole blood banking industry, we need synthetic blood. That is the answer. So that's the example in order to try to get you to dissect it at different stages of the whole thing. So that's called cycle of care. Okay, so I think what's most important is to, again, remember that an observation doesn't automatically make it a need. Just because the observation is a pain point or a problem or inefficiency or frustration, but you actually have to formalize it into the problem for somebody specifically in some setting that is going to have a measurable outcome when you solve that problem. And you have the insight into that someone really wants this, is going to pay for it. And that's actually called the funds flow. So you do a cycle of care along with the flow of money in order to make sure there's a sustainable way for whatever solution it is. It could just be a magic wand making the solution, but you've already thought through the end goal of that solution and work backwards after that to know that now I can do my concept generation of this problem. So tomorrow we're going to do observations in real life, be in a clinical setting at 3 different hospitals. You go as a team, you guys can figure out which parts you're most interested in observing and doing. Of course, we gave you all the tips. Take good notes. Sometimes what's most important is just to capture the observation right at the moment, but not interpret it too much at the time. Because there is also a tendency of capturing it in the way where I could have done it better by doing this already, and then you may be missing more of the point of where the focus of the problem is. Sometimes you might see a surgery and someone may feel faint, and if that happens, what you should do is, you get kind of lightheaded, just sit down right away, because we don't want anyone to fall, and of course, people are going to feel embarrassed if they say they're getting faint, so the key is just, sit down, rest, and that'll help. And there's no shame if someone felt lightheaded or something like that, or even nauseous. You can just go outside. Actually, even I was nauseous once as a med student. Not nauseous, but lightheaded. I was in an operation with an oculoplastic surgeon doing an orbital case around the eye. And basically, you're like standing there, kind of like retracting in a super tiny space, and you're like all crowded, and I guess you're all gowned up, maybe not even enough oxygen. And so I really felt lightheaded, and I was kind of embarrassed because you're with your surgeon, and you don't want to be the weak person who had to step away. But I stepped away, and it was actually a good thing because then they rushed me over to the room because I was just kind of a little bit out of it. They hooked me up to monitor, and I actually had some arrhythmia from low potassium from having been dehydrated and ill for a little bit, and so they gave me a bag of IV fluids right there in that same recovery room, and I was fine after that. But it happens to everyone, so no problem. Just make sure also that you don't touch anything if it's in the operating room. All the draped areas are quite sterile. Just try to stay out of the way. And then just try to be quiet, because sometimes patients are awake and they'll get attuned to any kind of excitement or frustration or problem. Any questions so far? Okay. Some of the specific types of interview techniques that we like to highlight is, again, to get to an example level, and also, because everyone here is sort of naive to begin with, just explain the basics of what's happening. I think that certainly you can read about a few things, but whatever you can't read and you still need to know, then hopefully you can get basics. And usually how we do that is you get it even from the trainee. So there's the attending, you don't want to bother them, but there's the resident, the fellow there, so you kind of ask your questions to them while you're watching what the attending's doing. So that's something that's very helpful. You can also do clarification. You can say, you highlight your reaction, why are you sighing when you said that? These are also, a lot of them are kind of self-evident, so don't need to go over them in detail. I think what's important for interacting with the physicians and interviewing them, some of the tips are, they kind of already will use their vocabulary. You see that even in patient care, sometimes they just happen to use words that are complicated and kind of rolls off without them even meaning to. Certainly they can do layman's language, especially when someone says, "What did you mean by that? I didn't quite understand you." But if you happen to be able to talk to them by already having understood some basics and having them your pre-reading before you ask them the interview questions, that's quite helpful. Because then they're easier to open up, the dialogue can be quite easier to go back and forth. That's when you rely on the medical training before. So So you can use the medical people in your team to help facilitate that. Also helps to a bit establish credibility and rapport because they know that they're not just teaching you one way, but it's actually kind of an interesting discussion for their dialogue because you have a skill that they could help them solve some other problems. Physicians don't mind being direct because they have lack of time, right? So they just get right to it. Sometimes with patients, you don't want to just be so direct with them, just more of a conversation and casual and ask them about their experience. But with doctors, you can be just like, what exactly was going on when you were doing this, and they'll tell you. But it's always good to have this common rapport with them. Maybe start off with finding something where, like, you both love dim sum in Hong Kong and ask them where to eat first, and they tell you tips, and then you start talking about that and stuff. And then the approach is, doctors tend to already have the solution too. They think they know, just like they know what the problem is. They also think what the best thing to, how to solve it is as well. So you kind of want to get them to stay more on the unmet need side as opposed to, they're like, oh, my student's here to do all this stuff for me. They're going to build this and make this for me, and I'm going to tell them what to do. So we kind of want to try to avoid that kind of scenario. More here to learn. So you can just read these basically, or follow up. You can say, well, you're an expert in this area. Can you tell me more about X, Y, Z? That really helps them talk a lot more. Trying to get specific on the treatment algorithms. Like, why did you do that in this specific case? The guidelines say to do this, but this happened specifically. And they may have some kind of reasoning that will help you out. Okay, so essentially, any questions on observing and interviewing? So this is the summary list again of the teams. It's where they go, what time. I think it's already on your WhatsApp.
So it is you have the WhatsApp group that the corresponding helper for each team that is on your WhatsApp group already? Yeah, right? So they should contact you already. So if not, then you let me know. And then so basically it's a meeting time of each team for a different area. And then so for local student, you just be there. If for the non-local student, the helper will come to the hotel to pick you up. So they will set you the time, tell you the time exactly. Any questions? Team 8? Team 3? Cardiology. So it's okay, so it's the same, so you just let the surgeon will let you know because it's the same doctor in the morning. So I'm not sure where is the cardiovascular clinic. So he will just guide you, and then so for the cardiology team, and then the doctor said that they will prepare the pizza and then in the meeting room somewhere. Yeah, that's what I heard from them. So different doctor have a different arrangement. Yes, so others that most of you can get your own lunch during the lunchtime after the morning visit, and then you have a lunch and then meet again. You just follow the instruction from your team helpers. Any more questions? So during the hospital visit, so basically there's pictures. So taking photo for the patient is not allowed. Okay. So remember this is very important. And sometimes you can take pictures with maybe the equipment and everything with the permission of the doctors. Okay. So basically you remember the things in your head, and then so like find one delicate person to take the picture. I think it's better if you need it. And also that after the clinical visit, all of you have to go back to here, Idendron. And then so we will have a debriefing here. So if your team is just finished earlier, then come back and then to find out your unmet need. So basically, you have to come up with the unmet need on Tuesday morning, and then we refine the unmet need after having the lectures, right? So it's really tight. So work hard tomorrow, and then find out, discuss with your team, do the research, and then find out the unmet need. And then so, and then we will come back and then meet all of you here, and then for the debriefing as well. Okay? So basically, after the clinical visit, we meet at the Idendron. Okay? So follow the instructions of the team helper. Okay? Here?
For dress, you should just be like business casual, for attire. Don't go in shorts and a t-shirt.
And also no flip-flop. No
No
flip-flop.
flip-flops.
Someone wear the flip-flop last year, I can't remember.
Okay, so we're done with lectures today. It's finally relief. You either can jump up and down and enjoy it, or go back to sleep. I mean, so, yeah. We'll, stay in touch on WhatsApp. See you now.